Okay, hi everybody. We're going to finish up our musculoskeletal section, and I'm going to do chapter 43. Some of this is repeat that we've already been talking about from some of our other previous chapters. So let's just get started. I want to point out the difference between a strain and a sprain when you're talking about tendon and ligament injuries. A strain typically occurs a little bit slower and over time, and it's because of overuse, then the tendon or ligament or joint gets strained, whereas a sprain is an injury to tendons and ligaments, usually from a traumatic event. You fall and twist your ankle, or fall on your wrist. That's a sprain versus a strain, but both of them result in inflammation and pain of the tendons and ligaments, and the treatment of that is what we call RICE. Rest, ice, compress, elevate. So rest meaning after somebody has been diagnosed with a strain or a sprain, and the strains usually will come on, like somebody who does something over time, like the repetitive grocery worker. Runners get this, they get strains in their joints or their heels and that kind of thing. And it'll start with a slow pain, but then they continue to use it, and then it really ramps up, and then they're diagnosed with a strain, so then they have to rest the joint or the tendons and ligaments that are affected. So rest it, meaning for 2 to 3 days after the initial insult or after they've been diagnosed with a problem, they should rest the joint. We're not doing range of motion during this time. Then the I is for ice it. Between the time of injury and up to about 48 to 72 hours, you ice it because you want to decrease the inflammation. Inflammation is always worse 24 to 72 hours after the initial trauma of anything. So after surgery, after head injuries, after burns, after any kind of body disruption where the normal process kicks in with the inflammation and swelling, it's worse between 24 to 72 hours. And then after that, it starts decreasing. And you want to help the body minimize the inflammation. So we do that by compression. You can put ACE bandages on in the strains or the repetitive strain injuries. You can wear braces. That's the compression, and then you elevate. You want to keep it up above the level of the heart because you just want to use gravity to help decrease the inflammation. So you're going to RICE any tendon or ligament injury and fractures for at least 24 to 48 hours. The fractures, obviously, we're going to immobilize it a little bit longer, but so be familiar with that. You don't need to know like the first, second, and third degree strains or sprains. You don't need to get into that kind of detail. You'll figure that out if you end up working in an ortho clinic. But for our purposes, just the general strains and sprains. Another thing that you can do after you've assessed, if somebody gets a sprain outside of the hospital, they'll come into the hospital, and 99% of the time they'll get an x-ray just to make sure that there's not also a fracture, because if there's a fracture, now we have to immobilize it in a cast. But if there's no fracture, if the bones are all intact, then they can just put an ACE wrap on it. Most of them heal within a couple, 2, 3, 5, 7 days, something like that, unless it's really bad. Then it can take up to 6 weeks or even longer. But once it's starting to heal after that, 2 to 3 days, then you can switch out the ice for heat, because sometimes as those muscles and tendons, ligaments are healing, muscle spasms can occur, and the heat will help with the muscle spasms. So sometimes you can switch to heat after that 48, 72 hour thing. Okay, I want to point out joint dislocations, because a dislocated joint does have some specific nursing implications for it. A joint dislocation is when the joint actually comes out of the socket. So we're mostly talking about shoulders and hips can become dislocated because they come, like your shoulders and your hips have this ball and socket. Dislocation is when it comes out of that, and that's considered a orthopedic emergency. The problem is when that ball comes out of the socket, you run a very high risk of shearing the arteries and the nerves that are also in there. And there's a couple ways that you can tell that a joint is dislocated. First of all, it's very painful. It will look funny. It will be a different length than the unaffected side. So, because usually the ball will come out like this and then go like behind, and so the limb gets shorter, and that's also true in a hip, and often those are results of traumatic injuries, usually falls. That's pretty much the classic one. Sometimes like overuse, so like basketball players that are using these and the tendons and ligaments are getting sore, and if they fall funny or move funny, it can dislocate. But those do need to be seen by an orthopedic surgeon quickly because of the risk for nerve and ischemia because of artery damage. So I do want you to look at the section that says joint dislocations. I want you to be aware of that. When you have a dislocated hip, and this is kind of common in the elderly, some signs and symptoms to watch for that might alert you to the fact that it's a dislocated hip is it will be beyond that hip will be cool and pale. The limb will be shorter. I already told you that. They should, if it's in their hip, they won't be able to move their knee, but they should be able to move their toes. So if you ask them to move their toes, they should be able to do that. If they don't, now you also might have some nerve damage down there, and you get a little bit more worried about that. So you need to evaluate if you're worried that somebody's dislocated a joint. You need to be very vigilant to assess their neurovascular status beyond the dislocation. So if it's a shoulder or something, you need to be assessing, do they have good pulses, any paresthesias, is it warm, can they feel you touching them? You need to assess for those things frequently because those nerves can get entrapped pretty quickly. All right, I want to talk about the tears of ligaments and in the rotator cuffs. And also in the middle of page 1158, it's I want to talk about this word. You probably never heard it before. Like this is epicondylitis, aka tennis elbow. So epicondylitis is the medical word for tennis elbow. Tennis elbow is basically a strain on the ligaments in the elbow, and it's really common in people that are repeatedly using this this joint with the tendons and ligaments. So that's why it's called tennis elbow, because the tennis players get it a lot because they're constantly doing that, putting a lot of pressure on these tendons there. People that are on crew teams or rowers, people that row a lot, gardeners, people that are pulling weeds constantly like this, they're holding with their hands and pulling, puts a lot of pressure on these tendons and ligaments, and it's known as tennis elbow. And the treatment of choice is rice. Sometimes if it's bad enough and inflamed enough and it's a high enough level athlete, you can inject it with steroids too, and that kind of helps reduce the inflammation a little bit quicker. Rotator cuff tears is often seen in the shoulder, common in pitchers, like baseball pitchers. They're doing this over and over and over, and then the tendons and ligaments that hold that rotator cuff in place get torn. Sometimes if the tear is small and a person can rice it and they're not a high level athlete, that will heal on its own. But in high-level athletes and people that want to use that joint again very quickly, they have to go in and have that repaired because there's not good blood flow there. So when those tendons and ligaments tear, they have to go into surgery and actually repair this, like suture them back together to repair those tears. The same thing is true in the knee ligaments, and these, I'm sure you've heard about this before, when somebody tears their ACL. Their ACL is their anterior cruciate ligament. Nobody ever says that because cruciate's hard to say, so you just say your ACL. And I want you to, let me explain this. So this is what happens. You've got, can you guys see this? Okay, so you've got a ligament, your medial ligament and your lateral ligaments. That hold the knee in place, and there's a really good picture of this on the bottom of 1158. See figures A and B that shows you what those ligaments look like. So what happens in an ACL tear is, like, if the foot is planted solidly on the ground, and this is common like in your here I am, in your like skiers and soccer players get this a lot. So people that have their feet planted really tight, and then if they get hit laterally, their medial ligament will tear, and if they get hit medially, either this way or this way, the lateral ligaments will tear. So the reason that you see that, like in skiers, because you know skiers have their feet like secured into boots. So if they get hit medially, like, or if they fall or move forward or hit a bad bump medially, they will tear that lateral ligament and vice versa. And then that leads to an ACL or an MCL tear, and usually those have to go in for surgery. The signs and symptoms of that is they're not going to be able to move that joint. It's super painful to bear weight on it. And you do all the same things. You have to immobilize that knee. They're usually in a brace. You rice it, and then you just keep it in a brace until that person can get to surgery. Sometimes if it's small enough, they don't have to go to surgery, but usually if you have an ACL or MCL tear, that has to go to surgery. So I do want you to read through that. Yeah, that's kind of all you need to know. So let's skip over now to fractures. And we already talked about fractures a couple chapters ago. I don't know why your book separates them out like this. I mean, it seems like this section should be back when we talked about fractures. Oh, here's an interesting thing. On the top of page 1160, a ruptured Achilles tendon. Your Achilles tendon, I'm sure you'll know, is that tendon right in the back of your heel. And it was just recently, our governor, Rick Snyder, the governor of Michigan, was trying to get in shape. He was out running, and I don't know if he fell or overstrained it, or somehow he tore his Achilles tendon. Super painful, very, very painful. But then he had to go back in and have surgery to repair it, because if you tear a tendon, you usually have to have it surgically repaired. And so then he was in the hospital recovering from his Achilles tendon repair and developed a blood clot, which, as we know, as we've been talking about, is a high risk for patients who have orthopedic musculoskeletal injuries. So now he's in the hospital being treated for, on blood thinners to get this blood clot to reduce before it ends up, causing a PE. So it's a big risk that you'd have to watch for your patients who have any kind of musculoskeletal trauma. But a classic case just happened here in Michigan with Rick Snyder. Okay, so I want to draw your attention to page 1161 when we're talking about the different kinds of fractures. This is important to know. Just the different ways that a bone can break. An avulsion fracture, as you can see in the top left corner there, is just you came down on a bone too hard. So like if you jump off of something and your feet hit, It can cause an avulsion fracture. So it's just that pounding, shearing force straight down. Hockey players who fall on the ice on their elbows, if they don't have their elbow pads on, it can, it can cause fractures like that. So anything that just falls really hard on a hard surface can cause an avulsion fracture. Comminuted fracture, that is still within the skin, but messy. It's not like a nice clean break. It's a like a messy break, but the skin hasn't been broken. That's called a comminuted fracture. Oftentimes that has to go to surgery to be reduced. Remember we talked about you put them in traction to reduce it, so that those parts which are all fragmented like this, you can pull them out like that, so then they can reanastomose nicely. Compression fracture is the same thing as an avulsion fracture, just in the spine. This is common in your patients who have osteoporosis, and they're walking a lot or putting pressure on their back. They can get compression fractures of the spine, very painful. A depressed fracture, you see that a lot in your skull, skull fractures like we talked about during Neuro Week. It's just it's usually in the skull where it just sort of indents. Epiphyseal, that's super rare. Green stick is often seen in little kids because children have very flexible bones. As you age, your bones get more brittle, but little children have very flexible bones. So sometimes when children fall and they hurt they hurt a bone, it will bend instead of actually breaking, and so the fracture doesn't go all the way through. That's called a green stick fracture, very common in children. Impacted, that's the same thing as avulsion and compression, same kind of thing, just sort of in the higher regions. Oblique and spiral are unique fractures in that the fractures go this way. This is commonly seen, unfortunately, in child abuse cases or elder abuse, because what happens is somebody gets angry and goes like this to, like if the bone is here and an angry person will go like this and twist the bone, then you often see these spiral or oblique fractures. So in the presence of a little kid or an elderly person, you kind of need to keep that in mind. An open fracture is a lot like a comminuted fracture, but the bone has been displaced so much that then it goes through the skin. Those patients are at very high risk for osteomyelitis because now you've exposed the bone to the external elements. So those patients are at more risk for osteomyelitis, so watch for that. Pathologic fractures occur in patients who often have metastatic bone cancer. Bone cancer in and of itself is very rare, but a lot of cancers like to mets to the bone. And once it gets there, it can cause those bones to fracture, and it's very painful. And a simple fracture is just straight across. It's kind of like comminuted, but it's just straight across. And easy. Those ones don't usually have to have surgery. They don't have to be reduced. You just can put a cast on that one and it'll repair itself on its own. Stress fractures, these are the ones you see in distance runners, people that run a lot and they're constantly pounding. Those bones can start getting some stress fractures in them. And then transverse is just, right straight across. Transverse and simple and comminuted are the ones that you're going to see the most often. Okay, then I think we already talked about some of the ways to repair bones. Much of the time that the bone can just have a cast put on it, and usually what happens is the person will come into the ER to take the person to x-ray. Yep, the person has a fracture, and then the ER physicians will cast it right there, and then usually what they'll do is they'll send you to the orthopedic surgeon within the next 24 hours so the orthopedic guy can analyze exactly what kind of break it is and what to do about it. Does it just need a cast, or do we actually need to go in and internally fix it with an open reduction internal fixation? And the figure 43.3 shows some of the different ways that they can repair those broken bones. And basically it's just like putting in screws and plates. So if you're good at hardware, you're going to know how to put a bone back together. So But anytime they go in and operate, again, that person is at higher risk for osteomyelitis. Okay, what else do I want you to know? That's kind of it, because we talked about that in the last chapter. On page 1165, there's more information about compartment syndrome. We always worry about compartment syndrome in our patients who have had bone injuries. So you're going to do the same kind of thing where you're watching for pulses, you're watching for warmth. You want to make sure that there's no numbness or tingling, and if there is, then we're worried about compartment syndrome because those arteries and vessels are getting compressed and the nerves are getting compressed. You need to notify the surgeon, especially if that's in a cast. Because you're going to have to get that cast off right away to relieve pressure. Okay. Keep in mind that, and there are, I'm on page 1166 now, there are some tools and instruments that you can insert into the muscle to find out what the pressure is in that muscle. And sometimes if that pressure is too high, they may have to do a fasciotomy. A fasciotomy is an incision in the fascia to relieve pressure from that muscle. It's the same thing as an escharotomy, whereas when in escharotomy we're removing scar tissue or hard bands that are essentially causing the same thing. It's causing compartment syndrome. The cause of it is different, but the result is the same. So an eschar in our burn patients with scars, and fasciotomies in our orthopedic patients who need the fascia opened up to get some more pressure relief. The rest of you don't need to know a lot on the next couple pages, because basically what it does is just going through every single bone and how to fix it. There's a couple of different little tweaky things. If your patient breaks a clavicle bone, you can't get a cast on that clavicle, so they usually put like a splint thing on there, like you'll see this guy on page 1169. It just kind of pulls that bone back, and the purpose is if the broken clavicle is like this, you just need a way to stretch it out so that it can reduce properly, so it can reanastomose properly. So some of these are just a little bit different than a regular cast. They do have these things now at figure 43.7 that have a bone stimulator that have been shown to actually stimulate bone healing a little bit quicker. So in your patient who needs to return to something like, like the professional athletes that do it for a living, they might need a bone stimulator on there. But Volkmann's contracture on page 1170 in chart 43.3, didn't we? I think we talked about Volkmann's contracture in the last chapter. I'm almost positive, but I do want you to know about that, because that's one of the ones that you'll probably be tested on Volkmann's contracture. But I'm pretty sure I already said that. If I didn't say it in a previous lecture, remind me and we'll talk about it in class. But I'm not going to repeat it right now. Now I want to flip over to page 1173 and focus you on hip fractures. The reason being, it's really common in the elderly, because this is why we want to prevent falls, because as we age we tend to develop osteoporosis. So then when the elderly people fall, they don't have really good strong hips. They break the hip, they end up in the hospital, they end up with a pneumonia, and it's a leading cause of death in the elderly. So we try to prevent 1, osteoporosis, and 2, falls, and 3, hip fractures. And then pneumonia and death, obviously. So I do want you to read a little bit about hip fractures. Hip replacements are pretty common, and they're way easier than knee replacements. So your patients who have really bad hips may need to go in for hip replacement surgery. Okay, so do read through hips and hip fractures and some of the gerontological considerations for hips. We do worry about deep vein thrombosis, and then the patient's in the hospital and they're not moving, and then they begin to degenerate faster than we would like to because they're not up walking. So we do want them up walking as soon as possible following a hip replacement. So you have to get physical therapy involved pretty quick. Okay, then you can skip over to page 1177. There's a really good care plan in there of taking care of a patient with a fractured hip. So if you're in clinicals and you have a patient with a hip fracture, this is a great resource. Now skip over to page 1183, some of the sports-related injuries. There's a whole area of medicine called, sports medicine. And, if you're interested, if you're an athlete, if you're interested in this, might be an area where you want to go work in, sports injury clinics. The biggest thing that we do as nurses, obviously, we want to prevent the injuries. So you might be the person working in the schools where you're talking to these students about how to prevent injuries, wear proper padding, proper helmets, that kind of thing. So there are some common sports injuries you'll see in table 43.1. We already talked about a lot of them, and it's pretty self-explanatory. If you're a tennis player, you're going to get you're at risk for tennis elbow. If you're a pitcher, you're at risk for a rotator cuff injury. If you're a runner, you're at risk for stress fractures. So based on what the sport is, soccer players, football players are high risk for ACL tears, skiers. So, you just kind of have to be familiar with what the sport is and the mechanism of injuries. Okay, and then I wanted to talk about, and I think this might be the last thing in this section, is amputations. Yeah, so amputations are kind of important, and they're fairly common. They're common in your diabetic patients because patients will develop diabetic neuropathies where they can't feel their feet anymore. Their feet kind of go numb, so they'll get sores or injuries on their feet. They can't feel it. That gets gangrenous, and so they might have to amputate a limb. A lot of our veterans now are coming home with traumatic amputations due to shrapnel or warfare in other countries, so they're coming home with amputations. There is a difference between a traumatic amputation and a scheduled surgical amputation. The surgical amputations obviously can be nicer and cleaner. And what they do in surgery, if there is a scheduled surgery where they have to amputate a limb, the orthopedic surgeon will go in and they try to do below the knee amputation, but sometimes they have to do above the knee amputations. And what they'll do is after they remove the limb is oftentimes right in surgery they will do very fitted dressings, because what they're trying to do is trying to mold the limb or the stump so that it will fit into a prosthesis, and that needs to be done right away. And so they often do that in surgery. The problem becomes as a nurse, you can't take that dressing off, and it's really tight and compacted so that it becomes molded. The problem is what happens if they start hemorrhaging or exsanguinating and it's all fluffed in this big fat dressing. So then what do? So now you have to be very astute to watch your patient's vital signs, because if they're exsanguinating and it's not going through that dressing, the first thing you're going to see is a drop in blood pressure, because that's the first thing that happens when you start losing fluids. And then your heart rate will go up to compensate for that. So those are some things that you have to watch for. And you also watch for fever, or their temperature and fever, because that's a classic first line sign that an infection is starting. So you need to use other things besides vision to make sure that that incision is one, not hemorrhaging, not leaking, and not getting infected. So you need to be careful with that. Usually after several days, then the surgeon will be the one to come in and remove those dressings the first time, and then you can start doing stump care and changing the dressings and things like that. That's step one, is stump / dressing care right after the amputation is done. The other thing that you want to be cognizant of as a nurse is you really want to start preventing hip contractures, because when you think about it, if you remove the whole bottom part of somebody's leg, there's a lot of weight there, and the weight helps pull the hip down. Well, if you've all of a sudden removed a whole section of leg, the remaining part of the leg tends to come up. And so you want to prevent those contractures, and one of the best ways to do it is to have your patient lay in a prone position, meaning on their stomach, because when the patient's in a prone position, then this hip is extended this way and it can prevent contractures. So you want to start telling your patient to lay in a prone position, you know, at least 20-30 minutes, 2 or 3 times a day. And once they're feeling up to it, feeling better, if they can lay in a prone position at night when they're sleeping, that's great, because it'll really help prevent those contractures. The other thing is patients who have amputations are often in wheelchairs, so they're often sitting in a seated position, which is also going to lead to contribute to contractures. So you need to get them up and walking. If you can get them in a prosthetic right away so they're up walking and returning to normal activities. The other big, huge nursing diagnosis that you watch for your patients with amputation is risk for injury, because you want them up walking, but all of a sudden their equilibrium and their level of stability is going to be completely different than it was before. So they're at high risk for falls. And that's your number one nursing priority. They do have a lot of other nursing diagnoses, like they are going to have alteration image, they are going to have grieving because they've lost a limb. So there's a lot of other ones that you absolutely have to engage your patient in and come up with some excellent nursing interventions. But risk for falls takes priority just because you don't want another injury on top of it while you're trying to get your patient to learn how to use their prosthetic and rehab and things like that. So so do read through that. So spend a little bit of time making sure from where it starts on amputations at 1185. Read through some of the complications, medical management. The figure 4318 shows you the different incision sites for the different ways that they do the amputations. And, oh, I know. The other thing with your patients who have had a limb removed, especially in your patients who have had like diabetic neuropathies and they have been living with a lot of pain in their legs, if they've had peripheral arterial disease, where they have a lot of claudication and it's hurting when they're walking, they can have a lot of pain. Well, after the amputation is done and that limb is removed, many times, and this can occur for years after that limb is gone, the patient will complain of pain in the amputated limb. It's called phantom pain, and you treat it exactly like any other pain, because pain starts in the brain, and the brain has been trained that hurts, my leg hurts. So even when the leg is gone, the brain is still remembering and recalling, and the nerves going down there are saying, ow, this is hurting. So you still have to treat the pain even though it's not there. And your patient might ask you, why is this still hurting if it's not there? And you can explain to them, because pain originates in the brain and your brain has gotten used to you having pain there. So if it starts hurting, let me know. We can give you something for pain. You do want to keep the stump nice and clean, but you don't need to do any heroic measures here. Just, you know, warm soapy water and a clean sock on the, like a stump sock on there every day is sufficient. And you want to make sure that it's not getting red or calloused, you know, just like you would do foot care on somebody. Okay, that's it. That's all I have for that chapter. Like I said, a lot of this is a repeat from before, but those are some things I wanted to point out that I thought you should know for that chapter. Okay, that's it. Next week, I think, is renal. All right, have a good one. See ya.